Right. It's 1:06, and we'll call the Seneca District Board of Directors special meeting to order. We will be meeting in closed session pursuant to Government Code 54956.9D1, conference with legal counsel, existing litigation, etc., as well as versus SHG. Also pursuant to Health and Safety Code 32106, report involving trade secrets, discuss revenue cycle services, philanthropic giving, giving well, giving tree. And with that, I will note the members present. Rich is here, Dr. Walls is here, Ryan is here, Kim is here, and I'm also here. All right, let's do the pledge of allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, so that moves us into public comment. There are no members of the public in the room. Are there any members of the public online who wish to speak?
No.
Sherry, I do not have anybody joined remotely.
Okay, thank you very much. And hearing none, we will move on to our agenda items. First up is our fiscal year 2023 operating budget. Steve, don't mind.
I guess necessarily have to have it on the screen, so everyone has it in front of us.
Yeah.
Okay. I'm gonna cross you guys up right off the bat, so if we could pass through the first 7 pages and go straight to the PowerPoint presentation. Who's running that?
Okay. TK just got it.
So TK, you want to go ahead and start the slideshow? Please. Okay. All right, so
Steve, are you unable to see it? I have it up.
yeah, it's in the file. If you go up to slideshow and start from the beginning.
Yeah, I have it up and I have it shared. Are you not seeing it? It has Seneca Healthcare District fiscal year 2022-2023 operating budget.
Yep, okay. Okay, so second slide. Here we go. Okay, so this is the same presentation I did last year, the same way to present the information, so I'm not going to go into it in a lot of detail because everyone's here, but Ryan, I'll give Ryan the highlights on this. And the way we go through the presentation is we trimmed our certain financial income statement indicators, revenue, expenses, and all over the last 5 years, which are all audited. And then we do our current fiscal year, and in a normal year, we would have started the budget process much earlier. And we usually project off, say, February. This year, because of the timing of things, we actually projected off of May, which is almost a full year. So the big thing here, Ryan, is just to show the trend in our revenue. That at 17, 18, 19, it was over 25 million gross, and then we hit 2021. A lot of that is COVID related. 22 is COVID and Dixie Fire related. But I think then we go to the next page, which is our net revenue. And the net revenue has stayed pretty consistent. The big thing about us is that 50% of our business, our revenue is Medicare, and Medicare is cost reimbursed. And so we can have lower revenue, but we get, if our costs go up, we're going to get more net revenue because they're reimbursing our costs. So it's a crazy world. So it just doesn't look right there that our revenue's gone down, but our net hasn't, but that's one of the biggest factors there. This is the one that's troublesome for all of us. Next page is our operating expenses, and you can see that we've gone from 15 million in 2017 to over 18 million last year and over 18 million projected again this year. So back to the idea that our revenue, our gross is going down, our net's being flat, but our expenses are going up. So simple math is revenue less expense.
Can you break down the expenses a little bit?
Yeah. So next slide. The big change is salaries and wages. And, you know, you can characterize or portray this however you'd like, but basically, with the exception of going 17 to 18, that was where we had a rise in our actual FTEs, a substantial rise in our FTEs. But every year, for the most part, we've been giving increases to our employees. One part of it is that we have negotiated step increases that are right now automatic. And then we have a negotiated cost of living or a negotiated increase with the union every year. So we've been giving anywhere from 4 to 8% increases. We've had the ability to do this, a lot of it to the support of the COVID money, a lot of it due to the support of supplemental payments, but it's unsustainable if we don't increase our revenue. Either we put a stop to increases, which is a very unpopular thing, or we drive revenue, which is a challenging thing. But I think that what this says is that not just me, because this has been over time, but leadership and the board that's been in place has been very supportive of the employees here. We've given increases when other facilities haven't given increases. We've retained people. We've made them whole during COVID. We've made them whole during Dixie Fire. So I think that this is kind of leading up to where we're going with the budget. I think we've been tremendous to our employees. So the next one is professional fees, which is mainly the physicians. There's contract labor, which is our registry, mainly in nursing and technical positions of lab and radiology. They stay pretty consistent from year to year.
Are the numbers of people that we are contracting with, individuals, increasing, decreasing, same? Your
in general terms, yes. You know, we cover our ER 24/365 with a physician. We've had a similar number of providers in the clinic here. Those are the two big drivers. As far as the contract labor registry, that goes up and down.
It looks like it's going down though, because I imagine that cost is going up, but our overall outlays has been trending.
Yeah, and the thing about the interesting thing about contract labor is it depends what you're buying. If we're buying RNs, it's very expensive. If we're buying CNAs, it's less expensive. Or we've even used phlebotomists. But it's interesting because when we go into preparing, we talk about the budget and how we do the staffing. You know, Judy and I sit down and we just say, here's our mandatory staffing, here's our required staffing. And we count the physical employed bodies we have when we do the budget. And there's no argument. The rest of it has to come from registry. And geez, just in the time that we've done the budget, the first pass of the budget, we've hired an LVN. You know, it just goes back and forth. The only thing is on certain positions, we have to do 13-week commitments. So we're, in some regards, as we bring in more people, there may be some overlap, but, you know, we just basically never have too many nurses. So Other expenses are kind of, there's not a lot there, pretty consistent. So after other expenses is our operating loss, and this is without the supplemental payments, being the supplemental payments we receive from Medi-Cal through the intergovernmental transfer program, and it's substantial, it's in the millions. 3 to 6 million, not much, 10, 20 million, some places do. It's amazing how dependent some facilities are on this money. It's really a reflection that the Medi-Cal dramatically underpays for the services they provide, and this is a way to use funding mechanisms to enhance the federal match and then pass it on to the providers. So you can see there's some variance in here. 2021 was when we started receiving the COVID money. So that's why even though our revenue goes down, you can see that we went from a $2.9 million loss from operations down to just under $2 million. That's reflective of we lost the revenue, but we got it back in the form of provider relief fund COVID money. And 2022 is we also received some supplemental funding recognized, and we'll talk about it. But so it's more, you look back to 19 and 20, and that's more of a typical snapshot of what how we do from true operations. Here's just the same thing. The next page, the operating margin represented as a percent, our loss as a percentage of net operating revenue. Okay. We move on to the next page after that. This is non-operating revenue. Non-operating revenue is made up of, with the way we reported here, it's our property taxes that we receive, approximately $600,000 a year. Any grants, donations. So again, it's pretty consistent. Occasionally we will receive a grant or a donation that pushes the number up. Okay, lastly, supplemental payments. So this is the mother lode. So this is the gross amount we receive from the state of California for multiple programs. Formerly the Prime Grant Program, now the QIP, Quality Improvement Incentive Project Program. What's called HQAF, which is the Hospital Quality Assurance Fee Program. This is a great one. This is where the big hospitals pay in and then we get the money. So then there's finally the rate range, which is where the managed care programs will adjust what they pay us based upon our volume of Medi-Cal, managed Medi-Cal business. You can see it bounces around. When we got into 18 and 19, the program it runs on a 12-month year. Each year, the funding has to be approved. The plan has to be approved by the state and then ultimately by CMS. And we got behind. And so 18 and 19 were 2 years. And then 20, they missed a year, or they missed part of the year. And then we got 2 years, or year and a half in 21. And then in this current year, what they did is they changed from a fiscal year, doing it on a fiscal year, to doing it on a calendar year. So for 2022, we only received the equivalent of a half-year payment on these programs. As you can see, the number dropped down. Fortunately, going for the budget year we're looking at, we'll receive a full year's payment on these programs. In order to get this money, we have to do what's called an intergovernmental, Okay, so after the supplemental payments, here's our profit and loss. This is an accounting thing. The auditors and generally accepted accounting principles don't consider the intergovernmental transfer to be an expense, and therefore they show our net income before the intergovernmental transfers. It's a balance sheet thing, if you will. So then we do these intergovernmental transfers, and you can see that again, 18 and 19 and 21, we had large intergovernmental transfers, and in turn we received larger supplemental payments, and then our number went down dramatically in 22 to reflect only a half year. So this is the bottom line, if you will. Over the last 6 years, 5 years of audit, and this year projected all profit, but you can see that the loss of a half year of the supplemental payments really took a toll on us in fiscal 22. So any questions about how we got here, all this information? Okay, so I just want to go real fast into just talk about two of the major things that have affected us. Okay, so COVID-19 in 22, COVID wasn't as prevalent from an operational standpoint and impact on our finances, and in turn, we did not receive or seek as much in the form of provider relief funding. We did receive $834,000 in what they call phase 4. This money was received within the fiscal year. We have it deferred because we don't show it in income yet, because we have until the end of this calendar year to spend the money. So after December of 2022, we'll go back, we'll add up all the receipts, calculate our impact to revenue, and then we'll claim any losses, expenses related to COVID, specific expenses against this $800,000. I'm highly confident that we're going to recognize this whole amount, because we'll be going back over an 18-month period, and we'll easily be able to claim this money, if you will. What we do is we file a report with the federal government, and we show what lost revenue we had, we show what direct expenses we paid, and then we compare that against what we received. And if we have at least or more than that amount, then we get to keep all the money. If it's less, we send some back. Again, I don't think that we will have a problem with that. We still have $183,000, $82,000 that we've received before, that actually the feds haven't asked for and haven't said what they want us to do with it. There's been no reporting requirement, so it was for the rural health clinic. Very odd the way they've done this. All they've asked is that we report our testing numbers, the number of COVID tests we do here, our positives, our negatives, and they haven't said, show us your expenses or show us anything. So just, and we've not received direction as far as whether or not that money, when that money can be shown as ours, or we need to do some financial accounting for it. We'll be undergoing what's called a single audit this year, where the auditors, our external auditors, will come in and they'll review all of our COVID money that we've received, what we've reported, what we've returned, what we've kept, and there will be a reconciliation of that, and they'll tell us whether or not we need to send any money back or we can claim more.
Is that going to be part of our regular audit, or is that separate?
It is. It'll be done in conjunction with it. The problem is, or the challenge, or the not straightforward part of it is that our COVID money was originally received, back in 2020, but we had a certain period. We had till 2021 to spend it, and then they gave us 9 months to do the audit. It's on and on and on. So they won't be looking at this 834 yet, because we haven't claimed it. it's very odd because a single audit typically is, the way they do that is that if you receive more than, say, $750,000 in federal funding within a year, then you have to undergo an audit. Well, we received the money, but they gave us beyond our fiscal year to spend it, which is they tried to fit a square peg in a round hole as far as the audits go. It was like the only mechanism that they could really utilize to do the audits, short of having the government come out and do it. So that's that. The paycheck, I'm glad that we're done with that. Still can't say it. Paycheck Protection Program loan was a loan that we received again back in 2020. It was forgiven in this past fiscal year, completely forgiven. We met the obligations of keeping the money, and we just never took it into income. So we brought this in, this 1.5 million. It looks great on the income statement, but the money was already previously in the bank. Dixie Fire. I was reminded by my wife that this time last year we were running for the hills or away from the hills. So glad we're not doing that anymore. Glad the skies are blue. But so we did suffer losses. Fortunately, the majority of our losses were in the form of lost revenue as opposed to direct expenses. The biggest direct expense we incurred was the remediation of the smoke damage, which was paid directly to the company that did it. The second biggest expense of COVID was the Dixie Fire was having to move our residents down to Chico and to have to rent beds down there and send our staff down there and provide subsistence to them. Meals, meal per diems, place to live, all that stuff. So we had submitted a claim and it went under intense audit. And what the insurance carrier is going to do is they're going to cut the settlement into 3 periods. One is from July, when we first moved the residents out, which was before the evacuation order, to the evacuation order. Then they're going to look at from the evacuation order to the order to return, and then all the way until we brought the residents back completely. So the big section is the evacuation time, and based upon their review and what we sent them, they've agreed to a settlement of $532,324, of which, as you can see here, $372.84 is lost revenue, $159,450 is in direct expenses. We have the check in hand. We've received the money. We'll record that as income in the current fiscal year. But we also have a remaining a loss that they've identified. The carrier and their reinsurer people have said that they've identified an additional $367,047 worth of loss, 242 in revenue and 124 in expenses. They're going to.
How did they come to that conclusion?
It just, they looked at the entire period over those three buckets, and over that entire period, they identified a loss of, or verified a loss of $899,000. And they just chopped it up into those 3, and they just said from the mandatory order to the time to return, there's no debate. That's going to settle. They're going to continue to negotiate with our reinsurer to see what we can get out of that other piece.
Does PDE have any liability in this?
I'm sure that our insurance carrier is going to, want to get in line with them, but we're not looking to PG&E for at least this loss. What they've done to our community and our, those types of the esoteric things, I guess, can be debated. But as far as our direct loss, our insurance is covering it. they haven't come to us and offered a loss. I believe in that proposed settlement that they put out there a while back was for property damage. And this is one of the reasons we did not go with FEMA. We talked to FEMA about our loss, and FEMA was really only looking at direct property damage and damage to infrastructure like roads. The county was a major FEMA thing with it.
So beyond direct property damage, what else are we looking at?
As far as,
Well, I'm just, in my view, the fire has harmed the whole community in terms of tourism, everything else that comes up here that goes with that. And I don't know if there's any, and that impacts the hospital, of course. I'm wondering if that's being addressed at all.
or quantify. Yeah, from that direct perspective, no, but I think that Sean can talk to it. He's had conversations with our state and federal representatives about this very issue.
That
About,
harms the, in my view, it harms the whole community. We're so dependent on people visitors.
right. And I think what the really, as we go on again and go into the discussion about the budget, is that essentially what we're doing on the budget this year is we're reloading on last year's budget, because we felt when we came to this table last year for the 21-22, this was it. This is when we were ready to go. Everything was in place. COVID's, is manageable from an operational perspective. And we were loading up resources to meet the needs, and everyone's excited post-COVID. And, we were doing great that first month, and then boom, we're out of here. And so the impact from that perspective was devastating. But again, now we're getting covered between receiving another round of COVID funding and the insurance settlement. So we keep, we've been very fortunate. We've been held financially whole. No one in our community was physically harmed permanently, kind of thing. And so we've weathered through this, and now here we are again saying, okay, this is what it's going to take. We're ready to go. So, okay, so I just wanted to go over these two things because they're somewhat impactful and relate to the statements. So TK, can you go to that other document, the PDF? So I'm gonna flip back to the beginning in y'all's package. There we go. Last TK, but I think everyone's looking at the budget. So normally when we do a budget, we look at it from three perspectives. One is we look at the prior year. So in this case, it would have been fiscal year ending 6/30/2001. And we look at the current year, which is 22, and then the budget of 23. 21 was kind of an anomaly year, obviously, with COVID. So we decided to go back and revisit the budget for 22. And as I just stated here, this was kind of where we said, all right, now this is where we're gonna load up, and there it is. That we're gonna move forward. We're going to look at having more revenue from clinic visits, and so I thought it would be valuable if we kind of looked at the budget for 22 and then walked our way through. So total revenue for the 22 was just under 23 million. We're pretty close on revenue for this year. And then the budget for 23 right now, we're looking at 24 million. So this represents an increase in some areas and decreases in others. That's why fiscal year 22 was kind of an odd year. We hadn't seen inpatient volume like this since I've been here 4.5 years. We had COVID-related admissions. We had incredibly long lengths of stay. We're very fortunate that we're under the emergency order because we received a waiver on our requirement that our length of stay cannot exceed 96 hours on the average. 4 days, we're just above that. And we're projecting now that we're going to go back to more normal where our length of stay is 2 to 3 days and not as many inpatients. At the same time, we're proposing that we'll now have more swing bed revenue. Now, Jerry and I talked about this a little bit. We'll have a little back and forth, you know, why are we projecting more swing bed revenue? Swing bed revenue is basically it's a rehabilitative stay. It's usually post-acute surgical stay. There's some instances where it's not. It has to be following a 3-day acute stay, but people could have respiratory therapy type services, but typically it's a physical rehabilitation. We have occupational therapy that we can do with some patients. So there's an ability to go out and to recruit for referrals where we can say, hey, you need to do a placement. The other thing is that some people will begin their care at this facility for a surgical episode of care. And so we know they're going to be transferred to Enloe or wherever they're going for now for an inpatient surgical or inpatient stay, and they're going to need some form of rehabilitation services when they return. So we can get in the mix on that and see if we say, well, when you're ready for your rehab stay, you can come back here and do it here. So we're confident that we can push up the swing bed revenue. The other thing is that we don't want to take swing bed patients when COVID's present. It's just that simple. That to put patients at a potential risk. Sean's talked about our ability to provide the isolation type environment for infectious patients. Our solution to that is to keep everyone away from them. But so there's a lot of things going on there. So we have reduced our inpatient revenue projection. We've increased our swing bed revenue. There's a big increase in our outpatient revenue, and there's a couple of things going on here. One is we're essentially closed for the month of August. So when we look at our outpatient revenue for 2022, that includes 11.25 months of the hospital being open. So we basically said that we think that running full 12 months and with what we see with the additional population in the area, that we are looking at across the board 10% increase in our outpatient revenue, ED visits. Steve Brown over at Almanor Physical Therapy has been just cranking out. He's busy. He's going into Friday now. I never worked Fridays before. We projected his increase to be 25%. Steen Jensen has started doing more cases here, so we projected a little higher increase than 10 on surgery revenue. So we have this disproportional increase within our other revenue areas based upon those factors. Long-term care, we've traditionally run at 15 residents on average. We have 16 beds, and unless everybody hangs with us forever, we're going to have open beds. So something between 15 and 16 is full. Right now we're at 13. We're doing the remodeling, so we've set the long-term care at 14.5. Just like the swing bed revenue, when we have COVID present, we do not want to take new admissions. We don't want to take admissions into the long-term care unit that are COVID positive. I think we've done a phenomenal job of protecting our residents at some financial expense to us. So we're projecting a average daily census of 14.5. For the year, we're at like 13.2 through 13.18. Last is the rural health clinic, and this is the real wild card in the budget this year. I did send you some corrected sheets because I looked at it and I said, that doesn't look right. And what we have for the budget for next year is, in short, we have Dr. Walls and Dr. Ware running their practices, less than full-time. It's understood they're both rightfully looking to retire soon, hopefully. We have the walk-in clinic. And then right now we have 2 open offices, two open clinic offices. So we put one provider, it's actually budgeted as a physician, looks to be our most likely get at this time. And we kind of projected the volume low on that. It'll probably take a couple months to get here. So we've projected the volume for that office less than what we would anticipate or expect it to be on a full-time ramped up basis. The good news is that when this provider comes in, they're going to inherit a panel right away. So it's not like they're going to have to really build their practice. It's just going to have to be about the people coming to them and for lack of better words, be comfortable with them. We've seen higher volume in our walk-in lately. Steve Hayden, I guess, saw 27 patients the other day, so it's a big number. So we have projected some increase over this year, but not a big increase. So that's a big mouthful. Let's talk about revenue, I guess.
Rich? Looked like you wanted to say something.
Well, I read your email. Did you get the answers?
Oh, yes, you sent
Did
me.
you have orthos, orthos?
Yeah, so if you don't mind, Jerry,
No, it's my phone.
I'll read this and then I'll read my response because actually they're really,
Just correct my question about PD volume to
Yeah.
staying.
Oh, fine.
I wasn't looking right at it when I wrote it.
no. Okay, so Jerry looked at the financials and said, am I correct in noting that we are not including any clinic visit estimates for the office vacated by the PAs? And then just to what I said, yes, we're only projecting visits for 4 office providers. So Dr. Walls, Dr. Ware, Steve Hayden, walk in, and then this one open office. We're projecting a provider in there. This includes projections for one office with a current vacancy, which is Dr. Cooper's former office. Although we are recruiting to fill all 5 offices with full-time providers, I do not think we could project visits revenue for more than one office. We also do not have, we have staffing for 4 offices. So on the expense side. Next, this is a good one. On average, how many patients per day are we estimating per provider? And I don't want to say it's an unfair question, but it's a hard question to answer really
I spent
really directly.
Yeah.
Because, again, we have 2 part-time providers. So, when they see patients, they're seeing 12 patients or whatever it is. But overall, our budget is showing 7 to 8 patients per day when you put it on a full-time basis. As mentioned, Dr. Walls and Dr. Ware, part-time. Dr. Cooper never came close to working full-time, even though he was, as far as his production. And then we have based the open position off of Dr. Cooper's numbers, which are incredibly conservative. Our target for a full-time provider is 12 to 20 patients a day.
So we're budgeting low, but our expectation is not at that level.
That is correct.
Okay, that was part of what I was trying to clarify.
And we, Dr. Walls and Dr. Ware are on a RVU basis, so they're on a production basis, so we've set their targets and then in turn set their compensation to that number. Steve Hayden's on a base contract and, you know, walking is what it is. And then the new provider will almost certainly, at least initially, be on some form of a guarantee. With incentive, yeah. So, did I miss estimates for ortho? So what we've done is we've included Dr. Watson will be here 1 week a month right now is the plan. We'll pay him $2,500 per visit to do his clinic.
What's 2,500 per visit?
No, for him to come out there.
Per day.
Yeah, that's good money if you can get it for the day. Okay, so. Good catch. Okay, yeah, should have just read it the way I wrote it instead of restating 2,500 a month. Okay, but I've not added any, I haven't contemplated really any clinic visits for him. We absolutely know he will have clinic visits. We already know that he's, got 10 people lined up for his next trek out here. So, or any surgical cases or associated revenue. And I said to Jerry, I said, I can probably add something for the clinic. I think I absolutely can put some visits in and some revenue. But what we're going to do on the surgery is we're just going to say that any cases he does is going to provide incremental profit. So whatever expense we add, he's going to add revenue, net revenue in excess of that expense amount. Right now, one of the big things would be a second day of the CRNA, a little bit more labor from the OR team, but we would. At first, he might do 1 case per day or whatever the number's going to be, so it might be a little rough, but eventually it would ramp up to where it would. The one what we could do is that I have projected an increase in Steve Jensen's surgical cases, so obviously you don't get those without the clinic visits. So I should probably go back and look at the specialty visits, and I think we'll end up bumping those up a little bit, and the associated revenue. So that's
Being very conservative.
Very conservative, yes. Well, I mean, Christine should be, Dr. Jensen should be able to.
Yeah.
For our visits and our revenue. You know, basing the budget on really conservatively low visit numbers.
Can we go back to, if we're done with that part, sorry.
Well, the one thing is basing the budget conservatively. The other is having goals.
Yes,
that are
yes.
Well, we have
a little more
goals.
exciting.
Yes.
Well, I have exciting goals, but
Exactly.
we have to be realistic about those things.
Well, and that's why I wanted to revisit this bed limit and long term, because, you know, I appreciate that we can anticipate potentially having higher volumes there, especially the swing bed, but I also heard Steve say a couple of times that it all depends on COVID also for both of those things. So are we putting ourselves out there by projecting an increase in swing bed revenue at this point?
boy,
Right?
these are small numbers. I mean, we're projecting less than
Well,
1 per day.
Almost a 50% increase, right?
Yeah, but I guess at the same time, you look at this and boy, you know, this is where you say, man, what is it? Liars figure and figures lie, but you know, if we have COVID, we'll probably go back to having COVID admissions. So our inpatient goes up and yeah,
That's a good point.
I don't know.
Do we need to do something regarding isolation?
We already have, we've done.
We're doing all we can.
We've done everything we can in the plant. Got scrubbers and all kinds of stuff in there now. That costs.
We have the room outside the nursing department
We're gonna
too.
keep that. You know, we're for not having negative pressure capabilities in the organization. We've done a pretty darn good job of keeping this thing tightened down.
Yeah, we've had, COVID admissions for the last 3 weeks, and so far our long-term care has remained completely unaffected, and so that's really good, because that's difficult, so.
And can I ask a quick follow-up on that, Judy? Do we have any sense for, I know our residents are vaccinated, right? Our
Yes.
staff are vaccinated. Do we have any sense for what kind of risk it truly does still impose or potentially impose on our residents? If
The
it's
entire staff is not vaccinated.
Yeah.
Some have,
We-
some have exceptions.
We have some with exemptions, and now we're waiting for the CDPH and CDC to come to some agreement on boosters again, another round of boosters. And then we're anticipating having Novavax as another vaccine option, because you can't keep getting the same vaccine expecting different results when the disease has changed quite a bit, so.
Yeah, and do we have any data yet, though? So, God forbid one of our residents does end up contracting it, right? They've been vaccinated. Do we have any data on how serious that might be?
I think
It's always potentially serious, those people are all high risk.
they're definitely a very high-risk population, and so that's why we have to remain so hyper-vigilant.
That's what I was trying to understand.
Yes. So we will, anytime we have a COVID admission, we are determining whether or not we need to put the long-term care back on lockdown. And it's been difficult because of the refresh project that's going on has limited some of our, access to different rooms and that sort of thing, and the whole sewer debacle and all of that that we're going to. But it's always a discussion every time we have an admission. What are we going to do to protect them?
Thank you.
Yes.
Do we ever determine what variant?
Yeah, well, the county sends a certain number of tests down to be classified by variant. And right now they're saying the BA.5 is the winning variant right now. That is what is most common. The BA, I think we were at BA.2 was the most prevalent up until the last couple of weeks. And people were getting infected but not getting sick. But recently, we're getting more admissions with this variant.
So the people are getting sicker?
Yeah, not as sick as they were with Delta by any means, but
Yeah.
still, it's been a little bit harder on some of our more vulnerable people. So.
That's a common complaint from patients, is they want to know what variant they have. Trying to tell them that we don't test for the individual variant for each patient.
Yeah, they can look it up on the public health website and they try and publish what they're finding when they do sequencing.
It's training today.
What's trending today?
Anyone else have questions on the revenue piece? Go ahead, Steve.
So I do have a question. Do we have statistics on how the population has changed this summer compared to, do we have any, whether it's anecdotal or whatever?
Of course, tourism, you mean?
No, I look at the country club and I see places loaded with people.
Town is
But I don't know what you're seeing in Chester, whether businesses are seeing much more business.
I know it's happening at
People
holiday
say it's slower,
market.
some people say it's slower. I'm
Yeah, holidays.
confused by
I think
that.
they're
Restaurant.
comparing it to last year, which was a fire, COVID, is up a lot, but no one's quantified it necessarily. Same thing, some people are going, wow, this is crazy. Some people are,
Yeah, it's a mixed bag.
It's a great question. It'd be
feels busier.
interesting to get a handle on that, on how to do that.
A lot of hikers, that's for sure.
That's true.
Last time we had a bad drought, the place was busy because this is one of the few lakes. that still
Yeah,
serve
there's no
water.
water in the valley.
I drove by Shasta the other day, there's almost no water, it's a body.
Yeah,
Yeah, it's
So
unfortunate that way.
again, I don't think people believe that this is the first normal year in a couple years. More normal, so it feels like there's a lot that's probably going on.
Okay, so I'm gonna just buzz through the expense section. And then I'm gonna go back to my presentation because I go into detail on some things and maybe I can just reference what we're looking at here. So if we look at, again, this summary page, oh, you guys know the expense detail. Which was that? Go back to the summary page, Brian, if you would, and everyone else. Just want to do it by functional category. We are on your first page of your budget packet, the thing that's on the screen there, Dr. Wells. So in the middle of the page, we get down to, the middle of the page is the operating expenses. And it comes down to a total there. 2022 budget was 18,300,000. Projected for this year is 18,000,006. Budgeted expenses for 2023 is 20,703,000. So short story there is we're budgeting for a $2.1 million increase in expenses. And I'll just kind of go through the elements here of what we have, and then we can talk about it a little more. So under salaries, we have an increase of $249, just under $250,000. Benefits increased $226,000. The benefits typically run 20%. So what we see here is that we have more employees receiving our health insurance, and that skews the picture. But regardless, salaries and benefits are going up about $375,000. Contract labor is going up $376,000. Professional, let me go back to salaries for a minute. So in the salaries, we projected in a small increase in FTEs, and go into some discussion on that. And we're also projecting an overall 2.5% increase because people are going to continue to get their 4% step increase for the most part. Some people are maxed out on that. We're not projecting any cost of living increase through the union.
Where are the FTE?
You know what? Let me do this. Let's go back to.
You want to go through the whole thing?
Yeah, let me just go through the whole thing and then I'll run through it real quick. Yeah, just, no, that's all right. It's like teasing you by bringing up these variances and not talking about them. The contract labor is just specifically related to that we're gonna have more contract labor, more registry people. Professional medical fees went up. There's a couple of things going on there. The biggest thing is that during the Dixie Fire, doctors that were on our RVU, Dr. Walls, Dr. Ware, Steen Jensen, they had no revenue, so they weren't paid. The ER physicians did not work, so they were not paid. Also, you guys will be voting on approving an increase for the ER physicians to go from 130 an hour to 150 an hour. That's about a $200,000 annual cost increase to us. I think it's the right thing to do. It's something we need to do.
We didn't vote on it because there's 2 abstaining, we didn't have quorum.
The pro fees, others, there's some legal fees. We're projecting them to go down. And then also there were some professional fees associated with the new bill that we didn't capitalize, the polling, the political consultant, the financial advisor. Supplies only shows a small increase, but there's a couple things going on there. The supplies are down because we're no longer in the 340B program, which is part of our decrease in other operating revenue. But we're also doing a refresh on our hardware with our computers, our laptops, our Surface Pros, our towers, and the spend there is going to be close to $300,000. Purchase service, I'll just move on from that one because we have a deep discussion about that in my presentation. Insurance went up 45,000, and we're damn lucky it did. They wanted to cancel us to start with. Then we went back, then they said, we're looking at 400,000, and finally settled on. We had about a $40,000 increase. The only issue with our new insurance is that everything stayed the same, but we have a $1 million deductible on wildfire. So we'll just take, we think we'll just take the money from the insurance settlement, throw it in our, that we have that one reserve, our little emergency reserve, and that'll put us comfortably over $1 million, about $1.3 million. And so we'll be adequately reserved and never have to use it, but it's there. Utilities and telephone, we put some increases in there. So we expect utilities and telephone, or natural gas to go up. So I'll go into the details on that. The good news for this year again is that we get a full year of the supplemental payments. So we're going to see a $2.4 million increase gross. So net income, we're showing that we're not just over $1 million, which is a decrease of 223,000. Then with the IGTs, unfortunately, they'll be larger because we're having a full year. And so the bottom line is we are projecting an actual loss for the year with this very conservative budget. So let me go into, TK, can we go back to the PowerPoint? If you guys go there and, oh boy, you can get to the Dixie Fire section and then just go a couple pages after that. Perfect. So in a visual, there's what I just said to you.
Page is this?
This is
Sharon Margaret.
Yeah, keep going, Rich. Oh, you are, Dr. Walls, one page after that one.
there.
Okay. So there's the damage. So other operating revenue, we didn't talk about much. What's really sitting in there is the recognition of the COVID money. Fortunately, that's something we've already received. However, the insurance settlement of 500,000, which we're recording in fiscal 22, we received in July. So kind of all comes out of the wash. One of the big things I need to bring to you guys next week is a formal cash flow analysis to see.
Steve, I'm sorry, just the very bottom row, that's without IGT, right? Without the IGT funds.
That's our bottom line. I like to call it almost our cash loss, because it's after we pay the IGT.
Okay.
So before IGT, we have a profit, but then when we consider that we have to outlay the IGT, then we have a loss.
Thank you.
Okay. Okay. So I talked about go to the next slide, TK, next page, you guys. That our operating losses, $2.6 million increase over this year, and we have more revenue, but we have a huge decrease in other operating revenue. It's really the difference between the triple P money that we recognize plus the insurance settlement. Expenses we went through are up, salaries and wages. Check that one. Okay, then the contract labor and then the other expenses. All right, so let's flip to the next page. And I'm gonna buzz through this because this is the discussion about revenue that I already went through. As we say, our overall revenue is gonna be up. Mainly it's gonna be driven from outpatient and nursing homes. Okay. Okay, we move on to the next slide. This is just the analysis of clinic visits over time. And we dropped off, we do 5 years plus the current year. We dropped off 2016. There were actually 13,000 visits in 2016. So we know that there's demand within this community. Dr. Walls knows there's demand within this community. Back in 17, 18, 19, he's doing 2,000 patients.
Seeing 5 doctors then.
That's right. I got it. Yes, sir. And you see what the, back to Jerry's question. I don't know who was in that menagerie of providers there in 2017. But saw 2,600 patients. Dr. Ware saw 2,600 patients. So the revenue's out there, the community's out there. All we need to is be there for them.
Yeah, see, just to go back a couple slides, if you don't mind, for our operating budget. Slide. I'm hoping maybe you can add an additional line on there. Not that one, the operating budget summary, maybe we'll above it. Thanks for that.
Next one, TK.
Slide 18. Hey, you.
There we go. So kind of what I was mentioning, this bottom line, I was hoping maybe you can add our net operating income, I'm sorry, our net income or loss, the bottom line total also on there, so it doesn't just show the part adjusted for the IGT. Does that make sense? Yes, so the actual true bottom line also. Thank you.
Now, TK, ready to go back to 21? Thank you. So again, the point is that we're projecting 7,700 visits. So we know with providers that we can well exceed that. And just simple math from there. So the next slide, 22. And again, this is where that first column, when we budgeted 22, we did have 5 providers. but it was 5 providers. And Sonia Troxel was part-time. So even with that, we were able to budget 10,000 visits. So it just really, it's not that difficult for us to get to 10,000 visits. And simple math or easy math, 2,000 visits, $250 a visit, $500,000, and all of the ancillary driven services and diagnostics that come from there.
Steve, I would just like to make a point is, one of the things you don't take into account that I can guarantee you will increase your business is the new electronic health record. I mean, there is no doubt that it slows us all down. And most recently, Dr. Ware has started using it, and she said it's a lot slower than what she's used to when she was dictating. So I think the efficiency in the offices will really improve once we get a system that allows us to work fast.
A lot of these, a lot of the operating expense increase this year is investment in that. You know, there's professional services that we're applying. So this is a year of investment into efficiency. It's really important to note that our operating expenses are going up, and in a lot of cases, it's to build that base into some efficiencies. You're going to actually start seeing some changes in the clinic that are going to potentially decrease or at least neutralize FTEs. So it's trying to prepare for what I hope is an absolute onslaught of outpatient business, you know, generating. So this is a budget that is leading into the future.
So that leads to then the need for providers.
Working on
You know.
it. My
So
work.
I'm just curious, what do you perceive as the most significant barrier to securing more?
That for every physician looking for a position that's 20 hours in front of them, competing against the whole world. Some of it has to do with, so you decrease it, a lot of younger doctors want to live, you know, in a place that there's lots to do at night. So it's a combination of, not that it's not beautiful up here, it's living in a rural community.
I don't know, so far.
Yeah, I mean, it does, it goes quite a ways. It's the number of offers they get put in front of them. So we're competing on a constant basis with all of these elements, all these artifacts, all these pieces that are out there. You know, we have been on the recruitment train over the last 3 weeks. Man, I'm not going to talk on wood, I'm not going to say it, but
We had four, right? Is that recall? Well, came out.
3.
Did you count the first?
Yes.
Yeah.
Then,
Dr. Gracie, yeah, 4 in the last 4.5 weeks, 5 weeks.
Yeah, so they're expressing interest and.
Well, there's definitely expressions of interest. We just have to close it.
Is it a matter of salary? Is it-
No. We, like I say, the base that, if they're not strict RVU, the base that we're providing is well in the market. A lot of them want to see, you know, how am I incentivized to do more, show them that. So there is not that. If they want to come here and they want to really turn tail, they can make a lot of.
I think this is your recruitment slide right here,
There it
to
is.
show them what they could do.
We do, like Steve said, in 16, Steve? Then we did 13,000 visits. Let's just calculate that in our heads. If we can get to even 10,000 visits, we're looking at 7,700 visits. If we can get to 10,000, that 815, by the way, which is a lot of investment, that's a loss of investment, is erased. I mean, not counting the diagnostic imaging and the lab and all the stuff that goes along with it. More people coming here for primary care, more people for specialty. So this is a bit of a, you know, this, looking at this budget, you're going, oh, gee, it's gonna work. But everything that we're doing is investing into our future, fixing things like Dr. Wall said, fixing things that are actually creating hindrances to us. So, yeah, it's kind of build into it. And that's just the only way to go. I mean, I think this board knows that I don't work on the philosophy that cost got to grow profitability. Doesn't work, you gotta grow. The only way to grow is to prepare for growth and then drive growth, so.
Great, what a great segue into expenses.
I literally need to step out for minutes, you go ahead.
All right, so TK slide 23, which is labor cost analysis.
There's the answer to your question, Rich.
Okay. So, again, the increase in salaries and benefits, step increases 4% only, and that's 4% over the year. So we used an average of 2.5. This time, no across the board increase with the loss we're projecting. No intention of contemplating cost of living at this time. Average hourly wage has gone down just slightly, 38.49 to 38.03. FTEs from 100.75 to 100.75 from 96, so 4.3. The FTE increases came from him admitting the two there. Part of it is just, and you'll see this in other departments, dietary housekeeping, it's evident that they just don't always have staff, and it's not a nursing staff where you have to cover it, you know, shorten our hours, or we don't have as much coverage. But in admitting, the one thing we did add as a full-time was, if you guys have come through the front door, we have a greeter now. That's used to, it's kind of a combination COVID and traffic cop for people coming in, so they don't just come swooping in and overwhelm the registration. Maintenance, we hired a maintenance supervisor to assist Linda McCurdy in becoming more of our overall facilities and safety officer. Very fortunate, we found a very talented young man, Jay Boddicker. And housekeeping, again, there's a little bit where we're short-staffed, and we also have a housekeeping supervisor, again, to support Linda McCurdy's efforts. She was housekeeping, she was maintenance, she was safety. We're going to see if we can teach her what a weekend is. Away from here. Dietary, same thing, just they have shortages. Lab, we were down a phlebotomist, we were using registry for that. We now have 2 full-time phlebotomists and a per diem, so they have time off coverage. Personnel, we added an administrative assistant to support personnel and whoever else can use administrative support, whether it be Linda, whether it be infection control education. Radiology, we're fully staffed in radiology. We have 2 techs and we have a true manager. So that's a great thing. Radiology is a big revenue generator for us. And again, radiology comes a lot out of the ED, big time out of the ED. So the decreases, med-surg, ED, long-term care, nursing, Lake Amador Clinic, we're down. We had Sonia Troxel in there. And then also Dr. Cooper had 2 MAs when he was here, and we had budgeting for just 1 MA per office right now. So that's our dynamic. And then right now we have 8.93 contract FTEs, which is up from around 6 that we've been running. Acute and ER nursing is 3.6, lab is 0.33. Lab, we have to provide some temporary support so that they can have time off. And long-term care, right now, we're budgeting 5 registry. I think that's 4 CNAs and 1 LVN. That's it. And then, of course, again, we're applying 2.5% to $7 million-ish. So it hurts.
But we hired an LPN for long-term, so he's in orientation.
Right.
We hired a registered nurse yesterday, and we're interviewing another registered nurse next week. And we have our CNA program going, so we are really hoping, our goal is to get rid of the contract labor as much as we possibly can.
And we're actually fortunate. Some of the other hospitals, their contract labor is atrocious. It's millions.
I think that's, I just want to say to the board that that's reflective of sort of the shift in what's happening, that we're having more people apply. And that's reflective of sort of the cultural shift that's happening and kind of ironing out some of the spots where it creates a hostile work environment, where it makes it difficult to work here. So that's kind of the way.
Any thoughts on the impact of people who are working remote, leaving urban areas and
I think there are a whole bunch of people that want to leave urban areas.
Two of the
I wonder
registered,
if that's accounting for what we're seeing more applications.
two of the registered nurses that we have hired recently grew up in Chester and went off, and now they're to the point where their children are going to be entering school, et cetera, and they want to come back home. And so that's really great for us, because that's a long-term retention, we hope.
And I do believe that we're going to benefit from some of the burnout that has been occurring over the last 2 years. I think that folks that are working in the valley and the cities are absolutely cooked. Literally, they're just thriving. And so while we have high expectations, it's a little slower pace up here. They've just in the last 2 years absolutely beat to death. So I think some of that's attributing it, and some of the professionals as well, not just nursing, but the nurse practitioners and PAs, and they're kind of going to put their hands up, oh, so done with this. So we're going to try to leverage that.
Well, when you think about that, it really speaks to the importance of quality of education our schools provide to people who go out prepared to get advanced degrees and then come back.
Okay, so this next slide, slide 24, I talked through when we did the high level review. So I think this, the purchase service is the one item. This has some high level discussion. The next page goes into depth. So I'm just going to go TK slide 25 we can. So purchase service, I had an $800,000 increase, and these are the main components of it. So the Cerner implementation cost is the project manager that you all approved at the last meeting. Looks like it's going to come in at a little under that, but we've already spent whatever we saved there. So we met with PDH yesterday, and they said one of the things that was key to their Cerner implementation was actually sending people back to Kansas City and going to Cerner. So we'll just have to see.
I think we'll probably be coming in just, by looking at, sorry, Steve, just the consultant has kind of rolled out their schedule in front of me. I think we're going to be probably closer to 275 on him, complete based upon his travel. So, we may have that 350, we want to put it in there because in fact, if that's I just want to have some flexibility in that number. That's why I asked the board for 350. I wasn't coming up with that, but, what we're getting from PDH and what their suggestions were, we might need.
So do they send people
They did
to Kansas City?
twice. To have barbecue.
Well, I don't know about community works, but that was Cerner's way of doing business. That's how they sold their product. Well, come to Kansas City and
Well, I've been there 3 times, so but I think the thing that, Stephen getting on the tangent here, so only that. One of the things that you have is the subject matter experts, like the lab people and the nursing, they literally Kansas City and sit in a room and do nothing but work with a nurse that shows them how to chart. They have doctors, the doctors show them how to chart in Cerner so they can come back and impart that on everybody. It's a value, it's completely submerged in the Cerner space. And there's no interruptions. You don't get interrupted, it's the way it works. So I found value when I went, and the barbecue was outstanding. Just so you know.
Martha Bryant.
You have to go to the original, no, not the
Yes.
one out by the racetrack.
No, don't go
Go
to
to the downtown with the flat beer and the rusty
And
pipes.
they have the greatest escape room in all of the United States.
I spent 4 years there.
What you did, Casey? Anyway, but it just didn't, that was brought up by PDH as being invaluable to their.
So did they do a train the trainer then?
They do, that's their methodology. But that trainer needs to be a SME, they need to know that thing through and through, so. Anyway, sorry, Steve, I digress.
So the next line item of Cerner related is the 150,000. Is actually for the Cerner people to come out here. They charge us their out of pockets, so that's the estimate they put forth, not to exceed.
And that's over what time frame?
No, 7 months. 7, Steve? Are we at 7? Yeah, 7, 6 to 7. The other thing that we found out from PDH is that they didn't have this slot cost. So it turns out that they spent a lot of money on it. Because apparently Cerner, this is interesting, they can only stay in hotels that have internal locking doors. In other words, they can't have a door to the outside. They say it's for security and safety as part of their policy. So, you know, they were staying at,
Rooms like
when
that
they were
around
requesting, they
here.
were staying at one of the resorts, like a nice resort. So I don't care where they stay, we're not paying more than that. So if you gotta bring it,
I'm just thinking.
whatever you gotta do.
Maybe, I don't know.
I think,
Just
Just
Western?
Western is the only one that, I guess, opens into a whole way. There's only part of it, it's only part of it, I don't know. That's,
That's what's your two-story.
two. Anyway, some interesting little tidbits from the PDH team.
That is interesting.
So the next item is, should we go live in March?
Not should. When we go live in March.
Well, yes. Just Portola, Eastern Plumas's go live date has been pushed. So it's,
Did they say why?
It's the S&P transition.
so just, that's our target. So in the budget, we said,
But has everybody been using the same team?
They're not using any of the Cerner implementations are gone. They had transitioned, I think, from Titanic over to S&P. I think the time it took to S&P to spin up and get resources going for this thing was pushed down 2 months. They were supposed to start in June. I don't know how it's gonna affect us. We have a call Monday with Cerner to get in a kickoff date, the actual kickoff date, and try to get our S&P consultants in place. Our consultant will be here Tuesday to start ours.
We're using S&P?
No, Cerner is.
Oh,
We're using a lead, so our consultant will be here. He's actually already reached out to S&P to find out what. So, we don't- No push.
so presuming we go live in
but the fact is, meeting a date is something that normally doesn't happen. in this field.
But you asked for it. We're in here.
Push for it.
Push for it, yes. Because it was supposed to be February, wasn't it? Yeah,
Yes,
I don't miss those things.
yes,
well, February is the go live, and then March would be like the first,
the actual switch over
yeah.
to maintenance.
So based upon just rough 40,000 a month. So we'd have 4 years, 4 months of both Cerner and CPSI for this budget year, as opposed to 22 when we just had obviously CPSI. The new IT management contract, there's a little bit more in the service level that we're paying for. They've beefed up our
Ransomware.
AVG whatever those guys do, the firewall, spyware. Also, we have more, oh goodness, more office licenses through them, so just a rough number is 50,000. Then the last one,
You'll understand this, Rich, so MFA is not required by CMS, right, multi-factor authentication. So the only way we can get multi-factor authentication was to up our Microsoft licenses. We have to have it as part of the rules now, so that's cost us as well. So some of these IT costs are directly related to requirements.
so the last, go ahead, I'm sorry, no, that's,
I just thought it was a trip on the word enhanced services, and I'm always looking for a definition of what enhanced services.
Yeah, we have 24-hour monitoring now, instead of just having like an AVG ransomware where it sits there and might pick out, might get up there 6 months. Now we have live patching, 100% monitoring, traps. So they're watching our system on a regular basis. They're learning differently. We have a 24/7 now help desk that they're supporting. So they are remote monitoring in, so we don't, so our staff on call coming in for ridiculous things. So there's a lot, that's the enhancements we talked about. They're also, they provide us a CSIO, CISO, Chief Security Information Officer, and a CIO, so they're part of the team now.
I guess my concern always goes to when Dr. Wells says, this is not working for me, I'd like it to be this modification to the system to give me a little more information or something you need on your end, and is that incumbent upon them to make that correction, or something that's just not working the way you expected it to work, or is that an enhanced service at that point, and you pay us more?
Oh, I see what you're saying. Yeah, so I think, if I may speak boldly, this company, the IT management company, is all around our infrastructure. It's nothing with our application layer, other than Microsoft applications. Dr. Wall's faces the working end of a system that just can't perform against the CPSI. And that has nothing to do with this. So that will be the responsibility of Cerner. Once we're live on Cerner, they will do maintenance and enhancements and things to that effect. So this is
our
our
question, then when they take it over, I don't find enhancement. They took over that for a long time. Just something I guess to be aware of.
Well, we're in a domain with them, so any enhancements will be global. Because we don't have our own system, we're in a domain. So enhancements will come as a group thing. And we'll be able to project them, let's say this enhancement is coming in March. And it's going to everybody in that domain versus just Center.
Yeah, so there must be a user group that prioritizes.
There is, and we're like a voice in that user group. Interestingly enough, and only anecdotally again, we're not in the same domain as PDH or EPHC or MODOC or others.
Or we win.
Well, they've split us up, and I think they do that for a reason, so that we don't have critical mass and have the greatest amount of influence over enhancements and changes to the system. Thought it was really funky. I am going to be reaching out with Liz on Monday. Sort of, why are you doing this? Why do you keep us separated? And I'm pretty sure so that 5 hospitals don't have critical mass in that domain. It changes.
I think we want that.
We do, but we don't get to choose our domain. Incidentally, MODOC and theirs are all village.
During the overlap period, as Cerner ramps up, will the costs of CPSI ramp down?
I think we're gonna be running a full live version for,
After that contract. Yeah, it's a year's contract. So, and then after that, we'll go into basically a archival only, we'll go into a warm zone. Basically, we have it available to us for technology purposes, but it will not be active. We won't be active in it. It's going to be historical. We only.
So what kind of communication has it been?
We're in discussion all the time. They're talking about, transitioning us to this more secondary system for read only, how we want to do it. We want to host it in the cloud. They're actually quite they're quite collegial with us at this point. They understand, they don't like it, but, they are acting with professionals. Absolutely. So that's fine.
But there's no way that we can negotiate a reduction in the overlap costs.
Well, I mean, I guess we could try to, since we're not gonna be using it from March on, and we can certainly try to say, hey, look, we're not using it anymore. Well, that's too bad, you got a year-long contract, and then it goes into the second step down. We can try. I have not been in this discussion. Okay.
So let me ask this question too, because are we gonna know that all of our documentation is gonna be done by March 1? Or the documentation?
Oh, there'll be a trail, there's a trailing piece to this, same thing with HRG and everything Steve's working on, there's gonna be a trailing period, but if on day one go live with Cerner, we will no longer be actively paying CPSI,
Yeah,
but there will be trailing, and there is gonna be a method by which there's a whole method by which we bring data from CPSI into Cerner preparation for physicians visits.
yeah, I just, back to Rich, your comment, the overlap, we will have to have a live system for at least probably a month to update and finish on the charting.
But it's gonna not be accessible by the doctors. In other words, when the charts get done, we're gonna shut off access to it, whereas we only, and staff will have access to it to provide physicians information. The physicians will be in the search space.
And the last item on there, there's a couple pieces to it. That as part of the change to Cerner, it's been recommended that we do a full CDM review, not just a scrub. We have a coding audit done, and we are still not compliant with the price transparency, full price transparency regulations. Something that we contracted with CPSI to do and that not go well. So we will be engaging a company to assist us with that, who has relationships with Cerner. So,
So Steve, I thought at one point we had put our charge master online, that doesn't meet the requirements for that.
it's part of it. The other part of it, there has to be a machine readable file that people can go on and look at the 200 services. Also, they need to be able to put like a code in or a diagnosis in, and it'll calculate reimbursement and reimbursement by payer. So you have to get your contracted rates in there. It's a lot. So
Jerry, I've got a question, since you brought up charge master. Are we talking at all about looking at our charges, given the fact we've got inflation, the cost of goods has gone up pretty significantly?
yeah,
What are we doing about that?
well, we've been monitoring our charges, and we adjusted all the lab charges to be more in line with our region, with the hospitals we compare with. Our radiology charges are still quite high. We just kind of let that go. So we have looked at that, but that'll be part of what we do when we do a CEM review, is they'll take 7, 8 hospitals that we want to compare with. It's basically the rurals in this area. We throw Enloe in there just as a point of reference. Whoever else we might want to consider in there. And then we do a market study, and we'll look at if we want to adjust. But again, we did clean up the lab where we're really consistent with everyone in our market area. We're high on radiology.
Okay, but I'm just thinking in terms of the essential service products that we use. I would assume they've gone up significantly. We're paying a higher price, but we're not charging.
Yeah, we haven't,
Okay, let me get to my bottom line.
no, we don't have,
I would like to see us not have a loss. Budget for a loss. This is a critical year for us.
what we can do is when we have the CDM review, we we can, since we're gonna be loading all of our stuff into Cerner, literally our whole master on purchasing, is we can establish a current market rate. We can adjust to that, because I don't think we'll be able to compare. See if I can finish the sentence here. When we do the market study, the data's old. I mean, it's not today. It's not a snapshot of today. So I don't think we'll see those markups. So we're gonna have to do it ourselves. We're gonna have to say, okay, here's our cost and here's our markup. We certainly can do that, Rich.
Yeah, I don't know if it's gonna be a significant amount of money, but I went to my bottom line, which is, you know, how.
There'll be some
let's
support.
break even.
Supplies, majority of supplies are bundled. So, anyway, yes, we will absolutely do that. The other thing is that after our meeting with, PDH yesterday, with Cerner, accounts payable, general ledger, financial reporting, whether it's payroll, all that sits in a separate piece of software called MultiView. Fortunately, Eastern Plumas, Quincy, and all of us will be on MultiView. We talked to PDH yesterday, and they said that basically they have to redo all their policies. Yeah, their old policies are kind of there, but they basically have to redo them. So we will be looking at doing a policy documentation, and hopefully what we can do is do it in collaboration with them, with those two other hospitals. We just basically write a book. Maybe MultiView has something they can give us. We don't know yet. We have our kickoff with them next month. So anyway, okay, with all that said, talked about the TK, if you're still awake, slide 26, that our net income loss, and Jerry, I got heard you loud and clear, about the linking it to the different profits. So when we go down to the income loss with IGT, in other words, our income loss after taking out the intergovernmental transfer we have to make, we're going to have a decrease of 1.25 million over the current year. Components of that are actual increase in net patient revenue. There's a $1.4 million decrease in operating revenue. This is the decrease in income from the provider relief funds, the discontinuance of the 340B program, and the Dixie Fire settlement received in last fiscal year. $2.1 million increase in total operating expenses, but we get full year supplemental payments. We get on the QIP, we're estimating 750,000, and on the rate range, we're estimating 2.3 million versus 330,000 plus 1.3 in 2022. So with that, this next slide, slide 27, TK. This was our cash position at the beginning of the fiscal year, fiscal 22, or the end of fiscal 21. Total cash on hand was $14 million. We're projecting at the end of this year, we'll have $15 million, just over 15 million. Of that 15 million, 643 is still this capital reserve. I have some cleanup to do on that. We'll be making the final payment on the roof. There's a couple other things to give you all a hard number on that. $1 million in deferred provider relief funds. The operating reserve, that's the one we talked about that we'll be adding the insurance settlement to get us over $1 million in the operating reserves should we have to pay out a settlement or just have that sitting there. So unrestricted cash of $12.6 million. So we're still in a very strong cash position. I will do a full analysis of cash flows, our commitment on the project, which will be the new build, which shouldn't be great because we're going to use the bond funds to start doing the large expenditures. So I guess what I'm trying to say in a roundabout way is that we have the ability to absorb a little bit of a loss this year off a conservative budget, and should things fall into place, which we're doing the things necessary for them to fall into place, you could easily turn that negative into a positive. So it's kind of where I'm at on the budget. I got a little bit of direction that we'll take another look at the clinic on the specialty visits. But other than that, I don't know if you guys want me to go back and look at anything else. You guys want me to?
Anybody have any other questions, comments?
I just wish there was more data, collective data on the community, what's going on in the community. It's impacted us, started with the.
It's always hard, unfortunately.
I'm gonna go back to our analysis that we did when we first got here about the percentage of out-migration. Based on the physicians not taking patients and just the lack of providers that were actively accepting patients. Those were pretty strong numbers that upwards of 55% were out-migrating primary care. Numbers reflected here too. We look doing 7,000 procedures a year, and we're doing 13 to 14. That's 50% right there where we've out-migrated. The need here is to bring in providers that are accepting, and then repatriate that percentage. And then I can tell you the budget's going to look a whole lot different, because we are in a position now from a staff perspective and a technology perspective to absorb a lot of load, a lot. We can, without changing staff at all, we can absorb a great deal. So now we have to get that great deal. We've got to chase that. So our operating costs should stay.
I know you didn't mention it when you asked the question about what attracts providers, but our new facility will be a major start.
My gosh, I can't sit through 3 more years of this budget. That's the truth. And being honest with you, I cannot wait for that to suddenly manifest and we get all these great providers. I mean, this has to happen now with that service and the things that we've got to deal with. So we have to look at our current campus, we've got to look at our current processes and operations, and we've got to build now. And then I think that's going to be the kicker. Like, that's going to be the big kicker.
To Rich's point, as a recruitment tool.
It's definitely, I mean, Modoc flat out, total recruitment tool. He flat out said that. It was a huge recruitment tool. But you know what? Maybe the doctors that we've had here, they've gone to the hospital and they're fine. And they're like, nothing's wrong here. I mean, even the orthopedic surgeon will bring on walk through our hole. He goes, okay, we can do it here. Okay. I think
You did say something about MacGyvering some things.
It's all about repatriating and bringing providers in that are gonna, that are, like Jake. Jake's doing one of our providers. He's doing 9,000 RVs
I think this is not only attracting providers, but so complex.
Yeah, I think so. On Pollyanna, but we have based this budget off of the most conservative volume. And you're right, I don't like a 50 loss either.
No.
Budget loss.
I know.
Can
Can we go, I would like us to
Again, that's
go
less IT
less
though.
conservative.
Because our
I'd like us to go a little less conservative.
Yes, I asked them to go with 10,000.
But Rich, if we're looking at the true bottom line, net income of 1 million, right?
Yes.
If we
The
take out the
ITT,
ITT, that's what it is, yeah.
Okay.
It's still at 51, I saw it. I'm like, fine.
When our budget becomes public knowledge,
It is
I
now.
want the public to know. that we will.
Well, we are within the profit, that's what I'm saying. 1 million. We're profitable. It's just, we're still working on our income operations.
The goal of this organization is to be net zero or a small EBITDA without the trouble, without the adjustments. Ultimately, that's where we really should be as an organization. For all this government money that comes in, stuff like that should be our job. That's my comment. And to get there, I think we're laying the right bricks. We're down the right baseline. This is truly,
Exactly what you just did, right?
Beautiful budget. I think this is a restructured, but this is a realistic budget right now. So there's only one way.
Thanks for putting this together, Steve.
Yes, thank you.
I know. It's hard to sleep.
Well, I want to make sure our community supports this hospital can, and then we get our new hospital that's like, and I want to make sure they understand that we financially fiscal shape. Some of that is, but
You know, anytime a community member, if they see this, they say, well, budget doesn't look that good, established. Come on back.
you just made, what you just said is what concerns people that don't look into it deeply.
Yeah.
They get the wrong impression. And I don't, this is a key time to make sure we give the right impression.
Agree.
You know,
Yeah, but I mean, if you go back to the slide where it talks about days cash on hand, and that's increased
Oh,
from
yeah.
last year, so I mean, it is all, yeah.
Now that,
it's healthy, it can be healthier, for sure. Thank you, Steve, great work.
thanks.
Thank you guys for setting aside a special meeting, because I really appreciate giving it the time, and it would just murder on regular board meetings, so.
Yeah, we should do this every year, I think. Thank you. Okay, so the next item on our agenda is the contract for revenue cycle services. Since we have that as an item for closed session, not the contract itself, but a discussion. If the board is okay, I'd like to table that until after our closed session. Is that okay? Okay. So then the next item on the agenda is the emergency room physician hourly rate adjustment, which I will be abstaining from, as will Dr. Walls, correct?
Yes. So if I'm gonna jump in, so we brought this up in the last board meeting, and we didn't have a quorum, we had two of our board members that have to abstain. This was done upon a market analysis. We're trying to move away from locum in our emergency department, because I can tell you that they're anywhere from 180 an hour to 220, depending on the company you use. We've done an analysis, EPHC has raised their rates, everyone's raising their ER rates to attract clinical ER physicians. We're also doing hospitalist work now, so we propose a rate adjustment from 130 to 150 to try to raise some more eyebrows out there and get some permanent ER staff in, get rid of locums. There was discussion in the prior board meeting, but we did not have quorum. So we're bringing it back for a vote with 2 abstain. There's conflict, so that's.
Okay, you want a motion?
I have,
Yeah, I'll make a motion to increase the rate to $150.
do I collect the votes?
Yeah.
No, you asked if there's any discussion.
Any discussion?
I concur with Sean's comments.
I concur as well.
Then all in favor, Rich?
Aye.
Thank you.
Okay, so then with that, we will go into our closed session.
Okay.
Okay.
All right, closed session is now closed, open session is back open. No reportable actions were taken during closed session. We're going to circle back to agenda item number 7, contract for revenue cycle services for Marlin Marcy and Inc. And I will accept a motion to approve both the MSA and SOW together.
So moved.
Thank you. For a second.
Second.
Thank you. All in favor, Rich?
Aye.
Brian?
Aye.
Dr. Walls?
Aye.
Ken?
Aye.
that, our next regular meeting is Thursday, July 28th at 3 o'clock here in the John North Clinic Conference Room.